Dear audience, let me introduce my PhD thesis, which is Infections in Chronic Lung Diseases. My name is Zsombor Matics. I work in the Department of Pulmonology in the Semmelweis University, and I am an internal medicine specialist, and my second specialty will be Infectology, because I'm interested in infectious diseases. That's why I have a vision that Infectology will be an inseparable part of the evaluation of chronic lung diseases. I have a team supervised by Veronika Müller, and together we have a mission to provide evidence-based data that draws attention to the importance of infectology. I have two projects ongoing. The first one was started in September of 2023, and it's called Comparing the Effect of Antifibrotic Treatment on the Incidence of Respiratory Tract Infection in Idiopathic Pulmonary Fibrosis. It's a systematic review and a network meta-analysis. The problem is that IPF is a rare but deadly disease with a very poor survival. The median survival is 3 to 5 years. And the best treatment which can be given to the patients are antifibrotic drugs. These cannot cure the disease, but they can only slow down the progression. So these are standard of care treatments now. And we know that these antifibrotics reduce the investigator-reported acute exacerbation and mortality as well. And behind this high mortality, acute exacerbation of the disease is the main reason. Acute exacerbation is the #1 killer in idiopathic pulmonary fibrosis, and it can be triggered by many things, like drug toxicity, pollution, but infections are the most important because we can impact the numbers of infections, and reducing the numbers of infections by any means can be the most crucial thing in preventing the evaluation of the pathogenesis of this chronic lung disease and preventing acute exacerbation of IPF as well. So we know that antifibrotics reduce the occurrence of acute exacerbations, but we don't know if any antifibrotics reduce the incidence of respiratory tract infections. So our aim is to investigate the effects of different antifibrotic treatments of IPF on the incidence of respiratory tract infections. Our clinical question: is there any antifibrotic drug associated with the reduced incidence of respiratory tract infection in idiopathic pulmonary fibrosis? To answer this question, we use the PICO framework, and our hypothesis is some antifibrotic treatments are associated with the reduced incidence of respiratory tract infection in IPF. And it is very important because if there is an association, we can rank the available antifibrotics based on their effect on treatable traits such as respiratory tract infections. So we conducted a systematic search with this search key, and after the selection, 27 eligible full text remained. And here let me introduce my results. My outcome parameters are the incidence of respiratory tract infections, and again, we aim to do this study because reducing the numbers of infections can be the most crucial thing in preventing the #1 killer, acute exacerbation. And the incidence can be very high in an untreated IPF. The range stands between 30 to 70% in a year of duration. So we included 27 randomized controlled trials in our research, and high heterogeneity can be seen in the pirfenidone group, where capacity 4 and 6 are outliers because they reported only serious adverse events and serious infections. And high heterogeneity can be seen in the antibodies group and in the other drugs group because we included different drugs with different mechanism of action. And based on our results, and based on a 52-week treatment period, the currently used antifibrotic drugs, named as nintedanib and pirfenidone, were not associated with a lower risk of respiratory tract infections. Now, we wanted to check which one of the currently used antifibrotic is better for the patient, so we conducted a network meta-analysis. We included 7 randomized controlled trials with more than 3,000 patient number, and here you can see my results of the network meta-analysis. In the right upper corner, you can see the direct comparison results. On the left lower corner, you can see the indirect and the direct comparisons results. And based on our results, there was no superiority between the two currently used two antifibrotics, named as nintedanib and pirfenidone. For overall ranking, we used the random effect model to calculate a p-score, and based on our results, pirfenidone might be a little bit better, but our results were statistically not significant. For confidence rating, we used the cinema, and due to a high incoherence and imprecision and relatively high heterogeneity and risk of bias, we gave a very, very low confidence rating. We conducted subgroup analysis regarding dose dependency. We included the same randomized control trials, and here you can see our results. There were no superiority between the currently used antifibrotic different dosages. Only in one exception, a single country study from Japan showed that 1,800 milligrams of pirfenidone usage were significantly associated with a reduced risk of respiratory tract infections, but multicentric studies didn't prove this effect. We conducted a subgroup analysis regarding the localization of the infection. We differentiated upper and lower respiratory tract infections, and based on our results, there were no superiority between the currently used two antifibrotic drugs. Of course, we had some strengths and limitations. Our data was pulled only from randomized control trials with high number of patients and events, and it was the first network meta-analysis regarding this topic. And our limitations is some concerns and high risk of bias. And our highest limitations are that there were no microbiological results reported in the articles, and no diagnostic methodology was reported in the randomized control trials. So our conclusion is that the currently used antifibrotics do not change the incidence of respiratory tract infections without any difference between the two drugs, so they can be considered as safe. And our implication for practice is that the currently used antifibrotic drugs can safely be utilized without risking increased incidence of respiratory tract infections. And our implication for research is that further randomized control trials with add-on therapies and real-world studies with respiratory tract infection incidence as a main outcome needed. So my first project is in an advanced stage, and I am happy to say that I managed to publish this article in eClinical Medicine, which is a D1 journal, part of the Lancet group. And here you can see my published article. My second project, called Comparative Analysis of Pulmonary Hypertension Treatment on the Incidence of Infections. This is also a systematic review and a meta-analysis. The problem is that primary or secondary pulmonary hypertension comes with a significantly elevated mortality risk. And we know that effective treatments like treprostinil, like sildenafil, like macitentan exists, but infections amplify mortality risk even more in pulmonary hypertension-related diseases. So our aim was to investigate the effects of treatments of pulmonary hypertension on the incidence of infections. Our clinical question: is there any specific treatment associated with the reduced incidence of infections in primary or secondary pulmonary hypertension? To answer this question, we use the PICO framework, and our hypothesis is some treatments are associated with the reduced incidence of infection in pulmonary hypertension. And it is very important, because if there is an association, then we can rank the available treatment based on their effect on infections. So we conducted a systematic search with this search key in 5 different databases in March. And here you can see my flowchart selection. At this moment, the full text selection is in progress. Here you can see my second project progress in a detailed manner. And to summarize, I have 2 projects ongoing. The first one was published in December of 2024, and for the second, I plan to submit it in November of 2025. And here I want to open the discussion part with the words of Albert Einstein. The important thing is not to stop questioning, and thank you for your attention.
I would like to ask you something regarding your first project. In the included studies, what did they report? What were the most prevalent pathogens causing respiratory tract infection, and are these different from the non-IPF population?
Thank you very much for this question. I was desperately searching for this detail in the articles, since I'm becoming an infectologist, so I'm thinking about pathogens, but I said it in my limitations that there were no microbiological evidence reported in this data, so I was very sad about that.
Can I ask regarding, if you are interested in infectology, do you have an idea that these pathogens might differ from the non-IPF population, or what do you think?
Yeah, I think yes. In the pulmonology clinic where I'm working, we treat a lot of patients with IPF, and with acute exacerbation of IPF is a very, very serious condition. The mortality in the hospital can reach 40%. So with acute exacerbation of IPF, many people come to hospital, and that's why I think that in the IPF population occurs more of the nosocomial pathogens like Pseudomonas, like Klebsiella, like Acinetobacter, than in the non-IPF population, who doesn't get that much of them to the hospital.
Congratulations on your presentation and on your publication too. I was just curious that in the clinical practice, what does an acute exacerbation of the IPF looks like?
Yeah, so as I said, it is a very serious condition. The patient usually say that they are started to cough, they are started to feel shortness of breath, chest tightening or chest pain, and the most serious complaint is the dyspnea. Usually when the patients come to the hospital, they are in a very bad condition. When we diagnose acute exacerbation of IPF, we have to do chest X-ray, but high-resolution computer tomography is the best choice, is the gold standard, where new opacities can be seen in the interstitial part in the lung. And of course, we can treat this with steroids and antibiotics and palliative care like oxygen, but the mortality rate is very high.
How these vasodilator medication are related to infections?
That's a very reliable question, I think. So what I wanted to highlight in this presentation is that I'm talking about serious uncurable diseases. Only lung transplantation is the cure for these diseases. So, and in my practice and in the pulmonology clinic, we can see suffering of these patients. So we wanted to decrease this suffering, and since we cannot cure these diseases, we want to treat those treatable traits, treatable aspects, which can cause the decrease of the suffering of the patient. So that's why we wanted to check in the first project the antifibrotics, and in the second project the vasodilatators, the impact of the vasodilatators on the infections. As my best knowledge, there is no direct effect on the vasodilatators on the infections incidency, but there can be an indirect effect by slowing down the progression of the disease.
I would like to ask you, from your experience here, you probably read more than the literature you showed us. Patients developing those type of fibrosis, is there a particular connects to specific infections like bacterial infections, viral infections, who develop these type of fibrosis more than others, or is it the sole predisposition of the patient? And my second question would be, I do see, or I assume that this will end up in fibrosis in very many patients after serious infection and prolonged mechanical ventilation. Can we do anything on medication to prevent that? We just use steroids, and this not on a regular basis.
Thank you for your question. Regarding the first question, again, there is no microbiological evidence, or a very little one. I have read a few articles which reported some kind of viruses, and there were observational studies which reported a few bacteria, but there was no high evidence.
Because during COVID,
Yeah.
I think we saw an extremely high rate of fibrosis, but we don't know whether this was due to the virus or due to the prolonged mechanical ventilation.
Yeah, but idiopathic pulmonary fibrosis is a completely different entity. Idiopathic, we know some factors which increases the risk for idiopathic pulmonary fibrosis, like pollution and smoking and MUC5 gene mutations, but we don't know the exact cause. We don't know that. And sorry, what was the second question?
If we could, in patients, we think they are prone to developing fibrosis, if we could start early treatment.
So if we diagnose idiopathic pulmonary fibrosis,
if we just assume that this prolonged infection could end up in a fibrosis.
There were studies with pirfenidone after the COVID, but I think at this moment there is no strong evidence for that.
So congratulations for your talk. Actually, it proved that liking the research of infection disease is infectious, because you receive lots of questions actually. My statistical question is related to your table showing direct and indirect evidence. Can you go back to your first project? Can you explain the others? What is the difference between the direct and indirect evidence? So first of all, what are the direct, what are the indirect evidence?
So direct evidence is when we compare directly to drugs. For example, we compare placebo to nintedanib. This is a direct result, and it is a direct result as well if we compare pirfenidone to nintedanib. But until now, there were no direct comparison regarding pirfenidone and nintedanib. So that's why we had to do a network meta-analysis to compare these two drugs together indirectly, because they were not compared together. So on the right upper corner, you can see the direct estimates. It's some kind of the same like the pairwise analysis in the previous forest plots. And on the left lower part, you can see the direct and the indirect comparison together. So, yeah.
Okay, so the network estimate basically.
The network estimate.
And actually now it's quite degenerate that it is not now just indirect, just a remark, because as you mentioned quite well, that no comparison between the two. It means that no direct part of the estimate in this case, but it's okay. Everything was quite good in your answer. Thank you. And I just want to make again a remark for everybody. Show me please the P scores as well. What I think is that you should less emphasize the superiority of pirfenidone, because they are essentially the same. I prefer much more the risk ratio. We have an indirect risk ratio or network risk ratio, 0.998. It is actually 1. So it's basically there are no difference between the two here. It's this is why I don't like P-score so much. I would prefer the table, because the P-score can exaggerate the differences. This is what I wanted to emphasize for everybody, that here they are the same essentially, with 1 risk ratio almost. So thank you again for your presentation.
Thank you very much.
How IPF patients die normally? Due to infection or the consequences of pulmonary hypertension, or what is the main, the most frequent cause?
This is a very good question, actually. What I see, that with time, with a short time, the functional capacity of the lung is decreasing very rapidly. And you know, when this is the last drop in the glass, there comes a banal infection. This can be the cause of the death of these patients. I think infection is my answer.
Okay, thank you.
But my answer is all the time infection. So.